Good afternoon, everybody. Thank you for asking me to come and speak to you. For those of you who don't know me, my name is Pramod Achan. I'm Chief of Orthopaedic Surgery at Barts Health. My areas of interest are complex hip and complex knee arthroplasty, but on the hip side, I do hip preservation, so from hip arthroscopy all the way on. I also have an interest in trauma, and I've been asked to talk a bit about the Symbios hip. Now, I feel I'm slightly different. I know guys like Paul Jairaj and Paul Culpen very well. I think the patients I'm dealing with using this, I put in a very different category. It's all NHS work. The patients, we have a very well-established pediatric orthopedic department, and they deal with all these conditions, so SUFI, Perthes, DDH infection, and because of East London, rickets too, and they manage them very well. But still, as a consequence of their treatment or the disease, you get failures. So children who present to us like this, and that's always posed a bit of a problem, both for me and for the wider arthroplasty department in our hospital. And somebody earlier was asking about how in the NHS you justify these. If you have an arthroplasty MDT, it's actually very easy to get consensus amongst a quite learned audience to say this is a different patient, there's something not right, or this is complex, and then to follow a different pathway from what is conventional arthroplasty. In the past, those patients had very few options, right? Non-surgical fusion, which hardly anyone does anymore. Excision arthroplasty is still talked about, particularly in the third world. Joint replacement makes everyone nervous, and when I gave a talk along these lines in Boston, the pediatric guys from Boston were hugely anxious about going down the joint replacement line. The arthroplasty guys loved it as a concept. And the other is to just ask the patient to accept dysplasia. In my training, the only hip options that were open to me when children or young adults came were these. So I trained for a bit at Stanmore. The CAD-CAM hip everyone will be aware of. Arish was doing them in reasonable numbers in those days. So I used the CAD-CAM hip. And one thing that was interesting about the CAD-CAM was they shaped it to the femur. So you got, very similar to the Symbios, you got one rasp and you got one implant. But if it didn't fit, you were pretty much screwed. And the problem is that happened reasonably frequently. Equally, being in London, I heard Johan Witt talk an awful lot about a similar patient group, and his solution was the SROM. So the SROM gave you the version modularity that we've been talking about earlier, but that also had a problem, and the problem with that was that you needed a straight stem, right? The femur needed to be, the diaphysis of the femur needed to sit underneath your entry point, and in the same plane as the condyles. And this will make more sense as we go on. So we all learn about the proximal femur. If I asked any of, I've got some of my senior registrars and a couple of fellows here, if I ask them what is anteversion of the proximal femur, they will define it. They will tell you it's about 15 to 20 degrees. And the interesting aspect, of course, is it's measured off the posterior condyles of the distal femur, right? Now, the problem with that is very different to what we see intraoperatively. No one's trying to, or not that they could, feel the posterior condyles of the femur intraoperatively, but what you're looking at is the proximal femur. And you're then trying to judge anteversion, which is measured off the posterior femoral condyles, from what you can see. And I'm not even talking about the minimally invasive crew here, I'm talking about old-fashioned open incision. And that's what you're trying to do. And stem geometry has always accounted for about 15 to 20 degrees of anteversion. Then I came across this concept of helitorsion, which made no sense to me at all, right? And yet I was still finding it difficult in this category of patients to find an anatomical stem that would give me a solution. And he described this as torsional deformity extending from the neck distally to the inferior portion of the lesser trochanter. So what we're really describing here is a little bit of rotation in the proximal femur above the level of the lesser trochanter, right? And it's something that we've always taken for granted. And it's really these pictures, so I put these together, but I've encountered all of these scenarios. So the gray circle is the diaphysis, the knee is self-explanatory, and then the green is where your proximal femur sits, right? Greater trochanter, neck, and head. And they don't line up. They move around. But actually, once you start looking at it, they move around in different orientations. And I'll tell you, particularly for the younger guys here, where this makes absolute sense, if you think, oh, he's just making this up, is when you do your femoral nails, right? So you look for your entry point, you get it right, and suddenly you can't go down the femur, and you end up going too posterior, and suddenly your cephalomedullary screw is not sitting in the center of the head. And in that scenario, it's absolute sense. You're explaining it in the trauma meeting, and you say, this proximal femur isn't like all the rest. Right? Nonetheless, when it comes to arthroplasty, we just standardize and say, well, these are all right. Let's just use either in an uncemented scenario what play we can. Modularity became an option as a consequence. Or in the cemented scenario, you try and rotate. You use a smaller stem and you rotate it within the cement mantle. And then Paul Culpen said to me in one of those MDTs, Prim, you should go to Evadon. See these guys, and I have a huge amount of respect for Paul as a hip surgeon. I was thinking, really? And anyway, so I went, and I understood helitorsion because I heard these guys talk about it. I looked at the implants, and I thought, I don't think, when they do a mapping of my patients, I'm not going to find much, right? So I've got nothing to lose. And that's how I got into this. This was kind of the old days of how they described helitorsion. But now, when you've seen a lot of this, so I'm not going to dwell on it. The only point I will make, however, is a point that Martin Porter made earlier, which is you've got to understand what the dynamic position of the pelvis and the acetabulum is. I think that does play a huge role in these patients. Also, in assessing leg length, we traditionally have just focused on the femur, right? But in these young patients with dysplasia or previous surgery or infection, they often get an associated overgrowth of the tibia on the affected side. So when it comes to leg length discrepancies afterwards and the attempt to correct them, it's not always just in the femur. And one thing that's nice about this CT planning software is it will tell you, right? It will tell you where the discrepancies are, and it will surprise you. And I think that was one of the early things that struck me. The next thing that struck me, probably more stark than anything else, is when these plans started to come out, right? And the green outline, which is where the femoral, the cut has been made and where the body of your implant sits, relative to the yellow, which is the neck and the head, right? Conventionally, that's where I'm looking for my 15 degrees of antiversion. But you can see here, in this case, there's a huge amount of retroversion, right? And then you start to look at the posterior condylar axis, and they all still look about 15 to 20 degrees of antiversion, right? And that's what made it puzzling. And it became a constant theme in these younger patients. And I'd seen both Alexi and Professor Sorielli's work on what their variation on that was. But in the younger dysplastic groups, it seemed much more consistently to be a stark amount of retroversion relative to the neck cut. And then this bit of the cross-section also told you why the SROM failed, right? If you look at the red line in the middle, it tells you where the optimal position relative to that would be of your implant, but the SROM's a straight stem, so it's always going to sit in one place, okay? And just to show you, this is what the design of the implant started to come out to look like. So in this particular case, this is anterior, that's posterior. It's not so impressive on the AP view, right? And all of you will be doing x-rays that look like that on the AP view. But again, what struck me on the lateral was that ability to get the neck going back and sit flush in the socket. And it was really consistently quite marked. So my experience, I was invited up to Wrightington to talk about this, and I was a bit embarrassed. I said, God, Wrightington. I said, I've only done, it's gone up to 14 now. This is the under 25-year-olds. I said, I've only done 14, and they said, that's more than anyone else in the country. And I said, oh, okay. So I've been there. The cautious steps about this, so I don't use the modular stems. In this group, you get one rasp and one implant. There is no modularity. This is not a solution for a bad hip surgeon to get away with tricky cases. For me, this is for a very experienced hip surgeon who is 100% confident that they can get their cup pretty close to where they plan to put it, right? And in dysplastic cases, that becomes increasingly more difficult. Right? We know where the bone stock is. We've got to put, if we're using an uncemented shell, you've got to put it where you're going to get at least 60%, 70% ideally of coverage, so it takes. And that may sit very differently from where you want your cup to sit, in which case you need to consider a face-changing liner or even cementing so that you reproduce the position. If you don't reproduce the position that you plan to put the socket in, it's going to fail. You're not going to get the results that you want. And that's equally true then of the original point about the dynamic positioning of the pelvis, is you've got to know that you've set the patient up in a similar position to which they were scanned. The other thing I would say is take care with the rasp. It is very, very sharp, and it will blow out if you're not careful. It's one of those things that when you're taking a trainee through, you really need to teach them to get to listen to the bone as you put the rasp in. And then once you've made the rasp, the implant will follow. Now, Tim was asking about outcomes earlier. We're measuring outcomes on all these patients, right? So it's a small number, it's easy to do. The concern I have, and we are going to present the work at the Hip Society when we think it's ready, but the concerns I have is none of these scores are validated in this age group. They're validated, as people mentioned earlier, in an older arthritic population. Where I think we're going to show a real effect is in the psychological profile of these kids. It's amazing in terms of what they're doing. So what you classically saw in failed pediatric hip patients is they were told to live with it. So we all know people who grew up with a limp, and the impact that had on their self-esteem, their ability to make friends, to play with people, to get married, to have what everyone would consider a normal life is phenomenal. And what we're seeing both from the older children and from their carers, and I've got one patient with Down syndrome whose parents are over the moon, because they say, sure, they don't complain of the pain anymore, but how it's changed their lives and their personality is phenomenal. I think that's probably where we're going to show the biggest impact for this patient group. I've put retroversion of the neck on the stem. It was consistently amazing to me is how much retroversion there was built in. And it's not retroversion relative to the femoral condyles. The downside, so complications, I had one patient come back that needed a hematoma evacuation. And then you start talking to this group, and then you suddenly start panicking because they are not used to being ill. They're young kids who just want to get up. So I had one kid who at 6 weeks came back and said he was having trouble break dancing. I had a physiotherapist call me at 4 weeks saying a girl she wasn't so happy with her balance on the trampoline. So it's kind of crazy stuff that you're not used to. And once they're out, after 6 weeks and they're getting back to function, there's no limit. This isn't an elderly person who wants to play 18 holes of golf and doubles tennis. These guys are putting those joints through the mill. So I'm just going to come back to this, and I'm sorry this is after lunch, but I'll just show you. So these are the images that you get, but what I've done is I've overlapped a few of them, just showing you the posterior condylar axis. That's the constant here, right, for femoral anteversion. So you'll see still in all my patients, if you took a traditional measurement of femoral anteversion, it is about 15 to 20 degrees. But when you change the constant, and this is showing that. So the orange line in the middle is kind of the femoral anteversion of all the patients, right? And that's what you'd expect. But the other two lines are the helitorsion, which is the yellow line, and the delta AH, which is the difference between the two. You can see how erratic that is in this patient group, right? And some of the outliers that sit there are actually the patients who our colleagues do derotation osteotomies on, right? And that changes a lot of the metrics when you come to do the surgery. And I'm getting increasingly, I don't mind them doing derotation, but I want them to know that they have an obligation to not offset the diaphysis on the proximal femur, because that really compromises our ability to do something when it comes to salvage. Okay, so here what I've done is, rather than using the posterior femoral condylar axis, I've just used the neck cut as the constant, and suddenly you can see the discrepancy on the rotation at the femoral condyles, right? So when people talk about standardizing an X-ray, right, most of our standardized X-rays are based around the position of the patella. So you would get a radiographer to standardize it by getting the kneecap pointing up and then you assume the version's going to be okay. But what this actually shows you is that is not a substitute for 3D planning, right? That's the variation. And you can also see the increased variation when you standardize like that on, it's a much bigger circle now as to where the center of the femoral head is. And lastly, we standardize the foot. So this is the foot progression angle, because we saw earlier there was some external rotation. But if they want a normal gait afterwards, they have to have a standardized foot progression angle. You standardize that, and then you see there's an overlap of both of them, right? So there's no consistency here at all. And this is one of the problems that you'll find is if you take an interest in the femur as a bone, it's actually far more variable than you think. And the fact that we've got away with it for a long time is testament to a number of things, right? So firstly, I always make the distinction. I sit in talks like this and I hear people talking about young adult hips, right? The normal hip, I think, past the age of 70 fails because cartilage ages, it can't tolerate activity, and so you get what is normal hip morphology with wearing out of the articular surface. I think that's a very different category of patient to the 45-year-old, let alone the under 25-year-old. And in that case, what we should be asking is why has that joint failed at 45? And invariably, it's because there is something different about it, right? And that difference will come out when you start to study it, and there are things. So I think CAM and pincer and you know that model of osteoarthritis we're starting to believe is real, but I think there are a whole spectrum of diseases. So I then was totally sold on the idea for this group of patients, but my question was, did this have a role in the normal hip that I was doing? I still saw a fair deal, and I'm not going to sit here and say they were all referred from somewhere else. Some of my own patients where the x-rays all looked great and they weren't happy with their joints. I also went in to revise some of mine and other people's hips at a later stage and found that the soft tissues, you've all seen this, right? You go in, you open the fascia lata and you're looking down. I don't do a hard hinge, I do a posterior traditionally. But if you were doing a hard hinge, or you can see it, you see the gluteus medius tendon looking white, that white shiny appearance that's avascular, sometimes with a little gap and a bit of fluid coming in through the middle. And I started to think about the balancing of the hip in the axial plane. Now, if you look in the literature, there's a huge amount of stuff talking about soft tissue balancing of the hip, purely talking about abductor function, right? So they're just obsessed with offset and abductor function. Not belittling at all. Paul mentioned it. It's absolutely crucial to good function. But if you look at a cross-section at the hip, and you think of the anterior and posterior structures, right, their tension is going to determine, one, the resting point of the hip, both in function and at rest, but also is going to determine the forces that are then transmitted at the bearing surface. And when this really took grip for me was last year at the American Academy, there was a whole session on trunnianosis, which is now the big problem. And we've all done it, right? You take a bearing surface that you use, put it on a poly or a ceramic acetabulum, and you spin it, it'll spin indefinitely. So if you think of that coefficient of friction and think what could disrupt it to the point at which you're going to get metal fatigue at a trunnion, or if you use a modular stem at that interface, it must be some kind of imbalance, because that is, if it's well lined up, it is too smooth an articulation for there to be a problem. I then spoke to Michael Mont and to David Llewellyn at the Mayo, and Sammy's here, we're looking to create a cadaveric model to study that a bit. But I think what the Symbios planning allows you to do and what the custom implant allows you to do is to get that balance right. So this is, again, Symbios' work on showing the range of stem torsion in the adult. But this is really what I'm talking about. If you line it up like that, then there can't be any friction or very minimal friction at the trunnion, is my proposition. This bit's just all hypothetical in my head, by the way. But when we put hips in, we could be putting them in like that, right? And what I know from the Symbios custom hips I put in is I'm not doing that, right? That retroversion that's built in means I'm likely to be restoring the soft tissue alignment and balance. But unless we start to study this, so we're I'm hoping one day I'll be able to come here and present this work to you. But the question I'd like, you guys are all clever guys. Does the soft tissue balancing of the hip in the axial plane play a role in determining torque at the trunnion head-neck interface? And I have a feeling it does. So that's the torque. I've got a couple of cases I can just show you very quickly, and then I'll take questions, or if anybody's got a burning question, shoot. This is just to show you the type of stuff, the other cases that I do. So that's a dysplastic hip. Again, looks okay on that view. This is where you see the value of having the custom hip, right, in terms of balance, and they get good function. This is another case. Somebody else did, so that's the only way I got that one. Yeah, so this was somebody who had it. They had the hip done. It was sent to me like that. Oh, sorry, can't see it enough. And again, that's the revision of that case with a custom hip. And the patient, yeah. So again, the retroversion seemed to give it a lot more stability, and they were happy. This was a pretty straightforward Sufi, seemed to be doing well, then fails. Take the metalwork out. You can see they've lost their articular congruity. And then get that, again, very happy. All right. Any questions? Shoot.
I think the big unanswered questions with a lot of these is, or one of the unanswered questions is what normal femoral torsion is. Because you've made the point that, do you define it from the osteotomy cut? Do you define it from the foot? Do you define it from the knee? Now, if you've got someone who's dysplastic, none of their femur's normal. So as they've grown, they've probably got an internal torsion of the distal femur. We've got a compensatory torsion of the tibia. So the whole thing's abnormal. So how do you then know that to bring that femoral anteversion down to 15 degrees relative to the back of the femur is right for them, and the back of the femur at the knee might be wrong? I think it's an unanswerable question, isn't it?
Yes and no. So I'm sorry if I've given the impression that the final objective here in the planning was to give 15 degrees of anteversion. It wasn't, right? It was to restore what was normal for them. You're absolutely right in that there is a single definition, and it is the posterior condyles of the femur, right? So that's not in question. And then the point that you make, which is that dysplastic femora are dysplastic throughout the torsional profile, is absolutely true, but this will tell you that it is. Now, then we go into the very sensitive subject of what do you try to do when you're doing joint replacement? Do you try and take an abnormal joint and orientate it normally? Or do you try and do the right thing for that patient's soft tissues, which ultimately are what make that joint work? And there is no answer. And all I'm saying is in this group of patients, I think what we're seeing is a little glimpse of an exaggerated version of what probably happens in all the mild subclinical dysplastics that we end up seeing with OA from 45 to 65. Yeah.
Yes, I really agree with your talk. It was very brilliant and interesting. We have started a program in France that we receive patients with bad results with hip replacement, and many of these young patients with well osteointegrated stems have some torsional problems, and we have started revising these patients, just changing the hip, the stem anteversion with very nice results. So it's true to say that in 2D we don't assess femoral anteversion. It's true to say that there is huge variations, and we have to take this into consideration to have good results.
I agree, and we of course have the advantage of the joint registry, and I think at some point, so we were having a discussion before, and there will always be skeptics who say, is this, this concept of helitorsion, the Symbios, is that for everyone? I'm not going to stand here and say it is for everyone, but I am increasingly more convinced that a 3D planning is probably warranted. If you took the resource and the cost out of it, is probably warranted, and I think it will only teach all of us a lot more about that orientation of how the hip joint works. And the beauty, of course, is that the hip surgeon's work is principally still going to be in that cartilage failure, no dysplasia, elderly age group, right? And that, I think we've got to start thinking those as two different patient cohorts. So there's one patient cohort where you don't need to worry about all that stuff, and this is overkill because that's the elderly. But I think it's as young as kind of 55 and below, if they're getting arthritis. In my practice, with the MDT, we're going to gun early for this kind of impression of getting 3D planning. And what we're finding increasingly is a surprise, right? And that's been my experience. Thank you all very much. Sorry, Paul, did you have one?
Well, so you're saying the 20 degrees of retroversion, abnormal anatomy, and we're replacing it with abnormal anatomy. Do you have any problems with hip stability or even wear rate?
So, I mean, so again, this goes back to the concept. The very terminology you use, which is abnormal anatomy, is because we're trying to standardize everything, right? So we say, but that's not abnormal for them. And actually what determines stability of the hip is the soft tissue envelope. And that patient's soft tissue envelope, to my mind, has been designed for a hip that's orientated in that plane, right? So there is no normal and abnormal, particularly, all I'm saying is the more specific the patient cohort we look at, I think there is a group like these patients, the under 25-year-old who've had either surgery or a massive insult to the hip. There is no normal for that group, right? And trying to pretend that their muscles were orientated even for a period of 18 months or 2 years, you know, that they got skeletal maturity and they had disease, to somehow work like my hip would work. I don't think that's the way it's going. I think everything will become more personalized, and the thing is we're finding differences, right? It's not that we're looking at these patients and saying, oh, actually their bones look exactly the same as everyone else.
What about, so you're saying that it's failed early because of the abnormal anatomy. So I'm talking about wear rates. So do you think then the long-term
Hold on. So again, what we can't do is lump all the patients together, right? So the under 25-year-olds, these all have pathology of some sort, right? SUFI, Perthes, DDH, infection. That's a separate category. For me, the kind of 38 to 60 young patient, right? That's considered the young adult hip. When you go to young adult hip talks about joint replacement, that's the cohort they're talking about. That is relatively normal looking anatomy, but there must be something wrong, right? So that's a different category. And your question around where, are you applying it to that group or are you applying it to an artificial joint? Because you can't, what we mustn't do is lump all of these together and say, hey, look, I heard this guy talk about it. He says we should be doing them. They're all very different. And I think we have a responsibility as hip surgeons to start breaking these categories down and understanding a bit more about them. But I think, you know, and I'm not, again, I think you will probably come up with an answer just as good as mine if you start thinking about it. And that's what I learned from this. A few people smirking behind you, they don't have that faith. Anything else? Sorry.
What you're saying is, and I absolutely agree, the under 23 or, you know, under 40 or whatever, they failed because there's some funny anatomy. Right. And so the hip the articular surface has failed because it's been abnormally loaded because of the anatomy. And the problem is if you reproduce that anatomy, you're going to make your artificial joint fail in the same way. You're still, or there is a risk, or should you be trying to
I'm not sure I agree.
Or trying to deal with the problem that led to them getting arthritis in the orientation of how you put the prosthesis in?
A very valid question. I'm not sure I agree. So we don't know enough about the young dysplastic hip, but the one that we do, or we think we do, is the natural history of the CAM lesion, right? And the CAM lesion disrupts the labral chondral interface, and then that's the trigger. When that's disrupted and you start to get delamination, that's the trigger for superior lateral. Now, that mechanism does not exist in an artificial joint. So when you say, let's try and reproduce that and we've still got the same problem, we don't have a labral chondral interface. So sure. So I don't think we can say that we haven't addressed the problem.
And the mechanical properties of the artificial joint are completely different. The cartilage is much more fragile and
sensitive to, sorry.
So if you take a first stage type hip where you've got abnormal biomechanics, you've got and overriding trochanter, the biomechanics are wrong. They classically complain of two different types of pain. Joint pain, and if you've opened the joint up or scoped it, you'll see there's fissure, abnormal cartilage. They'll also have fatigue type pain. When they walk for a significant distance, they get buttock pain and they have to stop.
Sure.
So what's your philosophy then in that case? And do you try and distalize the trochanter to improve the biomechanics?
So that space of open hip preservation surgery, things like Chris Peters describes very well, changing the shape of the head, that totally has a place. I think this comes when not just you've got fissuring, when the joint is destroyed, right? So aspherical congruity of the hip joint is still hip preservation for me. Nothing beats cartilage. Nothing beats cartilage. When the cartilage is gone, then that group of patients that used to get told, you're going to have to put up with this until you're old enough for a hip replacement, that's the group. So PAO, transfer of the trochanter, open dislocation, reshaping of the femoral head, anything to preserve the hip, whether it be arthroscopic or open, I think that's the way to go.
Fully agree with that, but I'm talking about a Tonus 3 hip, where there's no role for hip preservation. What's your strategy in terms of what you do to the trochanter and the biomechanics for joint replacement?
Right. So in terms of, I tend not to do anything in terms of osteotomy to the trochanter. I rely on the planning to restore the offset because I think their muscles will function. The trochanter, the margin of error, so I don't put a short neck in to keep the abductor function poor. Right, so I restore offset compared to the other side, and then I'm hoping, so even then with a misshapen, because they will have a different shape of trochanter, at that age usually the abductor function accommodates enough if you restore the offset. I've got Tim at the back.
I know you kind of lump it into the kind of younger, early failing group, but I think it's more fundamental than that. I think, up until now we've been, surgeons living in a 3D world, but only thinking in 2D. So we've been looking at our AP pelvis X-ray, measuring leg length and offset, and thinking about, inclination of the socket, with no real thought to the anteroposterior center of rotation. And we know that just by recreating the version doesn't mean that your center of head is in the same place, because the stem can be tilted sagittally, the head can be offset postally on the femoral neck. And I think there's just a fundamental change that 3D templating allows you to think of the center of rotation in 3 dimensions, which it is in 3 dimensions. And as you say, it affects not just the muscles that act in the coronal plane, but the muscles that act in the flexion extension plane as well.
I couldn't agree more. And in fact, Alexi's point about it's not just so the first step is the understanding with the 3D planning. The second, which he seems to have a bit more of a luxury at having than me, I've not had much success, is getting the post-op 3D CT, right? And I think that learning is going to make us all better and then give us a level of understanding. So it'll make us better because it will allow us to start putting it where, or confirming that we're putting the implants where we think we are. And we know from a bunch of work, Henrik Malkau's stuff to say, actually surgeons aren't as good as they think they are at any of these metrics. So I think it will help us with that. And then Martin's original point around dynamic studies with pre and post will give us much more knowledge, because I think we're pretty, I couldn't agree with you. In terms of medialization, lateralization, front to back, and then the orientation of the cup itself, we've got a lot to learn. And then I think you layer on top of that the dynamic position. So I was talking to Martin very briefly, but if you work in an environment where you have a culturally diverse population, so you have the Caribbeans, the Bangladeshis, the Somalis, as we do, then actually their position dynamically of the pelvis when they're standing are very, very different. They have a lot more flexibility in their lower lumbar lordosis, which means that the position at which we need the stability of the joint and the cup to function may be different for those patients. And this is all heading towards kind of personalized medicine, but I think these are the first steps. So agree, 100%.
I wanted to add a comment about what the question of do we have to perform some osteotomies of the greater trochanter in some cases? In my experience, I would just add more points. In the infantile coxavara, very often the greater trochanter is very high, and I would say very tall. In these cases, I had one case like this with a customer which was doing perfectly well, but she ended with a fatigue fracture under the greater trochanter because she was doing very well with the correct and excellent abdominal muscle force, but it was too much for this very specific anatomy. And now I would do something on this greater trochanter. I would not wait for the failure. And the second thing is probably either I would try to position the greater trochanter slightly lower, such a way, because you cannot, in these cases, you cannot implant a stem with a very high osteotomy level, such a way, the center of the ball remain in a reasonable distance from the top of the greater trochanter. If it's too low, we'll have too much constraints on the greater trochanter. I can show you if you want.
No. I mean, I've seen cases. So my concern is the number that fracture and fatigue relative to the number of patients that you see are small.
True.
If at the time of surgery you go aggressively to do a trochanteric slide or move the position of the greater trochanter, you compromise the fixation. So I would much rather go in at a second stage in that small group. But look, these are small numbers. I can't say to everyone here that's what you should do.
True, completely. And the second point is about DDH. In some extremely dysplastic DDH, the greater trochanter is not lateral, it's posterior.
Right.
And in these cases, this patient, even though they are doing well, they may have some weakness of the abdominal muscle, not because the offset is not restored, but just because the muscles are posterior instead of being lateral. And this is not new. Aubagnac was doing the same thing. He was doing custom stems plus a great trochanter osteotomy in order to put it right in the right place. But it's very few cases, true, exceptional.
So if you got a patient with obvious deformity with foot progression angle, pediatric,
yeah.
Patient would you still want to reproduce anatomy? And then cut severe retroversion, then cut external.
So we have an MDT. I think, again, you identify that patient. These guys, so the Symbios guys send me a HipPLAN. Most of the time I look at the HipPLAN. The only thing, they like to put the cup a bit higher than I like it, so I just pull it down a bit, and I say, this is fine, and then we go ahead with the plan. In a very small number of cases, I look at it, and the torsion outside of the hip seems very dramatic one way or the other. We'll discuss it at our MDT, and then I will speak to someone about whether they would consider doing a derotation osteotomy, say in the tibia, right? Because of course, when it comes to the hip joint, I'm probably going to restore as much as I can, the anatomy there. But of course, if we change that drastically, we affect the patellofemoral joint, we affect the foot progression angle. The whole lower limb works as one. And the advantage we have of working in a unit like ours is all these people are there at the MDT. We have, we treat hips from birth all the way to 100. So it makes it, and that's why we, as a community, have a huge advantage over the Americans. So if you go and talk to the Americans about this, you have the pediatric guys who are touching on hip scopes, you have the sports guys, and then you have the arthroplasty guys. And all of them fight with each other saying, you shouldn't be doing hip replacements in those patients, we don't have that problem, right? Okay.
We've got another one. One more.
Oh.
One more. Last one.
The other situation we have problems with the anatomy is in revision surgery. And actually, a lot of the revision stems you have the same problem in terms of, getting the center of rotation right. My question to you is, has anybody got any experience of using this 3D planning and custom design in revision hip scenario?
So I put that one case up, which was abnormal. The thing for me is, if you get what I'm going to call a conventional revision patient, who's the elderly patient who's failed, so when I was in Norwich, we saw these patients all the time, then doing an acute osteotomy or using conventional, a ZMR type revision implant, you're prepared to do that, right? Because you're already moving into the kind of first revision salvage of the proximal hip step work. In these younger patients, you don't want to do that. But the software works. Software works, and you know, as I put up in that case, we had to use it with an implant in situ. But most hip surgeons have a revision armamentarium where I don't think they need to go down this line. They can use what's out there pretty effectively. I think that's the danger, is we overcomplicate it, right?
The main issue when you go to hip revision and you want to do 3D planification is that you have hard difficulties to predict the position of the new stem. When you remove a well osteointegrated stem, you have some bony defect, obviously, and also you have many artifacts. The images can be analyzed by the engineers in a good way. So, on my opinion, you tried uncemented revision stems, and it was not good. So.
We rarely do this because we've had some failures of fixation because of the very problem that Alexis is mentioning. So we have to be very careful in custom stems for revision.
So we have a prospective study actually regarding maybe 20 or 30 stems. The philosophy is different. We do cemented revision stem. And it seems that we have very good results in terms of accuracy, and we can predict the position of the stem, and so we can do some correction of the femoral neck.
Thank you.
That's great. Thank you.